Hi everyone, and welcome back to Heart, a podcast from the Poly Heart Center, where we have real conversations about what matters in heart health and talk to the experts here at Poly about how to keep your heart beating strong. Today's topic and guest is a special one. We're going to be talking about interventional cardiology and complex heart disease with Dr. Barbara Lawson. She is Poly's Director of Complex Coronary Intervention. That is quite the title.
It is. Thank you for having me.
Yeah, thanks for being here. So to get started, let's just dive right in. What is interventional cardiology? I had never heard of that term before working here, and I think when you're a doctor, it's a pretty special specialty, but maybe for the average person, they might not know what that means.
Sure. So interventional cardiology is a subspecialty within general cardiology that focuses specifically on the treatment of coronary artery disease. So putting in stents for people who have chest pain, for people who are having heart attacks, things like that. That's sort of big picture interventional cardiology. Within that, there are even further sort of subsets within it, those pertaining to structural heart disease, which has to do with minimally invasive valve repair or replacement, or closing holes in people's heart with catheter-based interventions rather than with open heart surgery. And the other sort of subset is peripheral intervention, so opening blockages in non-heart arteries, so arteries going to the legs, arteries in the chest wall, arteries going to the kidneys, things like that.
Okay, so now I have multiple questions. So it sounds like what you do is, it's called interventional because you're going inside of the body, but you're not doing surgery.
Correct. Yes, we are intervening on something that is wrong with the heart, but without having to open the chest.
Okay. And the structural heart disease, that term implies like something wrong with the way that your heart is structured.
Correct.
Whereas coronary artery disease is a disease that you acquire over time.
Correct.
Can you talk a little bit about coronary artery disease, what that is?
Yeah, so coronary artery disease is the sort of big picture name for what most people think of when they think of like hardening of the arteries or atherosclerosis. Mm-hmm. So plaque deposition in the arteries that then over time can lead to narrowing of the pipe. So if you think of a pipe and then there's plaque that deposits on the inside of it, now the lumen or the sort of area in the center of that pipe is no longer as big as it used to be, so the flow through it is impaired.
Okay. So what made you interested in this specialty, like when you were a med student and a cardiology fellow?
So I've always been very hands-on, I guess. I played sports when I was young, so it was sort of like that, like go out and do something rather than just read about it or things like that. Mm-hmm. And I think that sort of parlayed well into a subspecialty where I was doing something with my hands.
So as Director of Complex Coronary Intervention, what are you exactly responsible for within Poly? Like, what does the average day at work look like for you?
Yeah, so I do a large portion of the procedures that I do are considered complex. And that can come from patients that are within the VCU system. It can come from referrals from outside cardiologists whose patients have something related to their coronaries, and we can talk about what complex really is, but that they don't have the technique or the technology to treat adequately at their institution. I work pretty closely with the cardiac surgeons here in terms of helping to determine for high-risk patients whether an open heart surgery is necessary or whether we might be able to fix it with a less invasive strategy, albeit with risk. And then I'm not the only operator within VCU that does some of these complex things, so I sort of have a sort of consultant role with some of my colleagues on my team in terms of helping to decide if, when, and how they should choose to treat their complex things. On a day-to-day basis, it's variable. I am in clinic 1 day a week, and then I spend 3 days a week doing procedures, 2 of those specifically coronary, some of them straightforward, some of them complex, and then 1 day a week doing structural interventions. On a given coronary day, our cath lab is quite busy, and I would say on average, each operator probably does somewhere between 5 and 10 procedures a day.
Wow. That is a lot.
That's
pretty
busy.
Way more than I would have expected.
Yeah. Some of them are quick, if there's not anything to fix, if we're just taking pictures and everything looks good, or they need a referral, the procedure takes 10 or 15 minutes. If it's a complex coronary problem that requires a lot of tools and tricks and steps and things like that, it can take 3 or 4 hours. So it just kind of depends on what comes your way on any given day. Some of them are outpatients electively scheduled. Some of them are inpatients who've come in with symptoms that are significant enough that they need to be, hospitalized and more urgently evaluated.
Okay. So what you said at the beginning about patients who are referred in from other places, like complex implies that, so there's like, you get a stent put in, there's sort of like an average stent situation.
Sure.
And then there's more complicated ones that are probably beyond the scope of us to be able to maybe talk about. I don't know, I guess we could, like, what would make, just again, let's say a stent, like more complicated?
Sure.
What situation would that be?
Yeah, so part of it is anatomic. So where is the blockage that we need to work on? If it's right at the beginning of the blood vessel where it comes off of the aorta, that's a higher risk or a more involved procedure because you have to make sure that you're covering it completely, but you don't want to be sticking out into the aorta, things like that. The blockages can be at a branch point. So if you think of like a tree trunk, if the trunk has blockage in it, but also the branch has blockage in it, how are you going to treat it where you're covering both? We end up doing what we call bifurcation stenting, so 2 stents going in opposite directions and then meeting in the middle. And then there's sort of lesion-specific characteristics. So like, is there a lot of calcium there? If there's calcium, you might have to drill through the calcium to create a channel. You might have to do intravascular imaging to sort of look inside the vessel and figure out what's going on. Those types of complexity or interventions are done generally in an institution where there's cardiac surgery backup because the risk profile is higher. So in a cath lab where there isn't cardiac surgery backup at that institution, that's a person that the referring would send our way for us to do here.
I gotcha. Yes, that is something we say about PCU a lot, is that we care for the sickest, most complex patients. So we're sort of like where the buck stops in terms of the work you do, and I think a lot of other providers do here. So you mentioned that you're in clinic 2 days a week, which means like not actually going in and fixing the pipes, but maybe just talking to people about what they have had done or what they need to have done. So where do you do that? Is that all at the hospital, or do you travel around the state?
Yeah, so I do clinic every Monday, and right now my clinic alternates between the ambulatory care center here on the main campus and the Stony Point location out in south of the river. And on a given clinic day, I see anywhere between 20 and 24 patients usually. A lot of them are coronary disease, some of them are structural disease, and some of them are just general cardiology because the need is so high that we see kind of a little bit of everything. When the new Reynolds Crossing location opens, which I'm told is soon, my ACC clinic will transfer to there. So eventually, once that's the case, it will be Stony Point and Reynolds Crossing alternating every other Monday.
So how have advancements in technology changed the way that you treat coronary artery disease or what you do generally across all different types of interventional cardiology?
When interventional cardiology started as a specialty, it was very sort of rudimentary. There was one type of wire to use, a small selection of balloons, and a very early generation stent. We're currently in the 3rd generation of stents, so they've made a lot of advancements in technology there to minimize the chance of clotting a stent or re-narrowing a stent down the line, things like that. More recently, some of the changes that have been helpful, especially in the complex coronary world, are things like intravascular imaging, so putting an ultrasound camera or an infrared light camera inside the coronary and looking from the inside out. And that helps us determine how calcified is this, what kind of treatment do I need aside from just the ballooning and the stenting. It also helps us with safety in terms of looking at the stent after we've put it in, making sure we didn't disrupt any of the tissue before or after the stent, things like that. And then with the calcified lesions, we do what's called atherectomy, and there are now multiple different types of atherectomy, which are basically roto-rooters for the coronary arteries. So different types of drills, whether they're just going straight, to create a channel, or whether they're orbiting inside the vessel to hit different areas of calcium. There's a laser we can put inside to sort of soften plaque. And then the most recent things are things like intravascular lithotripsy. So the same way that people can have lithotripsy on kidney stones that are made of calcium, we can do lithotripsy in the coronary arteries to sort of break up the calcium in the coronaries so that a stent can fully expand. So those are some of the recent advancements that have really made our job easier in terms of end game, but harder in terms of more steps and things like that. But definitely has advanced our field a lot.
Are there any new tools or techniques in the field that you're very excited about right now? Specific things?
So structural cardiology is definitely exploding right now. Structural being the ones that deal with valve replacements and things like that. So historically, in the last 10 to 15 years, the valve that we've been replacing by a catheter-based intervention is the aortic valve. And then that has extrapolated also to the mitral valve. But what's coming down the pipeline now is a new catheter-based valve intervention or valve replacement that's for the tricuspid valve, which is newly approved by the FDA. We are hoping to have it at VCU in September is the fingers crossed goal. And then the other thing that we do have in the meantime is something called TriClip, which is a minimally invasive valve repair for the tricuspid. The other thing that we've just started doing at VCU in the last few months is something called renal denervation, which is a catheter-based treatment for high blood pressure or hypertension, where for patients who are on multiple blood pressure medications, and this is something where we go up into the kidney artery and we treat the inside of the artery to sort of fry the nerves, if you will, so that they stop driving up blood pressure. So those are some of the things that are coming new that have been sort of groundbreaking for our field.
Cool. Yeah, I heard about the renal denervation. That it was the first time in Virginia, right? That Dr. Thomas, I think, did
That's
it.
Exactly right.
Yeah, that's exciting.
Yeah.
And you mentioned like using a camera to go inside, and you also mentioned earlier about sometimes you're just going in to take pictures. So as part of what you're doing, like diagnosing this disease before you treat it.
Correct. Yeah. So some patients are coming to us with known anatomy. They've already had their pictures taken somewhere else and they're coming for us to fix something. Some people are coming in because they had a symptom, their doctor ordered a stress test, the stress test was abnormal, and we're coming to look directly at the artery. So a lot of the non-invasive testing can be suggestive of plaque that might need to be fixed, but the gold standard to really find what's going on is the heart catheterization. And if it's something that we can fix on the spot right away, we'll go ahead and do that. Some of the more complex stuff, we take the patient off the table, have a discussion about risk and benefit and strategy, and then bring them back for a planned intervention, just so that we know that we've addressed everything. We have all the appropriate equipment, support staff, things like that.
It actually sounds really fun. Like problem solving and but also almost like, yeah, building is fun to me.
It is.
Whatever, building, engineering, I don't know, tinkering.
Yeah, I really enjoy what I do. It's been, the field has grown. We are obviously an academic center, so I'm teaching new cardiologists how to do, what we do, both at the basic level, but also at the complex level. So it's a really rewarding field.
Okay, talk a little bit about that, about your role in education. Because I know you're the director of the Interventional Cardiology Fellowship Program.
Correct.
So what is that like, teaching people to do this for the first time?
Yeah, so it's actually, it's hard. The general fellows are coming right out of internal medicine and starting in cardiology. They've never done a heart catheterization ever. They've done procedures, they've gotten IVs into blood vessels and things like that. But this is starting from ground zero, and the fellows have likened it to like something that's as easy for me as like brushing my teeth and trying to teach them to do something that's like rocket science. They're like, how are you going to teach us how to do this? So at that level, it's definitely the most difficult, but it's also potentially the most rewarding, because being able to teach someone or direct them how to do something without actually having to necessarily put your hands on it. So sometimes we do. Sometimes I say, let me take this and I'll show you. But sometimes I can just describe, this is how you're going to do that. Try it this way, move this direction, things like that. And then just to see the joy of like, oh my gosh, I just did that, Yeah. So that's very rewarding for me. I'm really, my mom's a teacher, and my dad's a physician. So for me, I sort of brought the two together into one career, which is kind of cool. At the interventional level, when we're teaching them how to do the stents and things like that, they've already done 3 years of general cardiology. So they are proficient at the catheterization procedure to take the pictures, make the diagnoses, things like that. And then we're just teaching them to take it one step further, where putting a wire down the coronary, putting a balloon down, things like that. That is difficult, but not as difficult as starting from square one.
Do you remember when you started from square one? Like, do you remember the first time
Oh, yeah.
you did what you just described?
Yes, I do, very much so. And I remember the angst that goes along with it. And I remember one of my senior fellows sat with me before we went in. He was like, this is how you, work the stopcock, and this is how you, adjust this, or this is how you inject, and things like, it's like things that should be really easy, but when you put 12 new things together at once and say, okay, now go do those, it's like, me now? And of course, there's always someone above you. It's not like we're throwing people in there to do things by themselves.
Right.
We say we're training people, and patients get a little bit nervous, like, well, I don't want anybody practicing on me. But it's like, ultimately, it's me doing it. I'm just instructing someone on, how to manipulate their hands and things like that. So it's stressful to be a new person, but it's also reassuring to know that you have someone right next to you that's doing it with you.
Okay, so what goes through your mind when you're preparing for a particularly difficult case? How do you mentally prepare for something like that?
Yeah, the biggest thing for me is, I know I have the skill set, I know what I'm doing, but the biggest thing for me is how can I do this for this patient safely and effectively? So we have a lot of tools in our toolbox, and it's definitely not a one-size-fits-all kind of field. So when there are multiple ways that I could do an intervention on a given patient, I sort of go back to the patient themselves. How old are they? How frail are they? How functional are they? And that helps me decide, which of these strategies should I use. I can also look at how strong is their heart function, how bad are their kidneys, things like that, to help determine, is this could be effective, but it's higher risk. I could do equally effective with this, whereas in that patient I might do something different. And what I always tell patients, sort of when I have the discussion about what we're going to do has more than your average risk for your run-of-the-mill stenting procedure. But what I always tell them is if I didn't think I could do it safely, I wouldn't offer it to you. But that's sort of my focus, is like, I know I can do it, but how can I do it the most safely and the most effectively?
That is very reassuring, I'm sure, for your patients. I feel reassured just hearing that. So what advice would you give to a patient who maybe has been told by a different doctor that their case is too complicated to treat? I don't know if that happens, but maybe it does.
It does, for sure. I would say you should always consider getting a second opinion. The second opinion may be the same as the first, but there's no harm in asking somebody else, because what is too complicated to one operator may not be too complicated to another. And patients often get nervous about asking for a second opinion, thinking like, oh, well, my doctor's going to be mad at me or something like that. But I just would reassure people that our goal in the end is to make sure that you get the best care possible. And if that's not something I can provide and someone else can, by all means, we should have that option for you.
All right, so can you walk us through like a particular success story where a complex intervention made a really big difference for a patient?
Sure. So just recently I had a patient who had been found to have newly weakened heart muscle. Okay, so the normal heart, when it squeezes, pumps 55 to 65% of the blood out of the heart. This patient was functioning at 25 to 30%, and he was very limited as a consequence. He was very breathless, his energy level was low, he was having some pain in his chest. So his primary cardiologist had done a heart catheterization and found that he had a totally occluded right coronary artery, which was felt to be chronic in nature because the body had created some natural bypasses to that area. And then the artery going to the front of his heart had about 95% narrowing in it with significant calcification. So he had referred the patient for consideration of bypass surgery, and the patient had been turned down because he had significant lung disease. And so he came to me, and we did a pretty involved procedure with a temporary heart support pump to make sure all the organs were getting their blood flowed while we were stressing the heart out. We did the drilling that we talked about. We did the lithotripsy with the sonic pressure waves. And then we used the intravascular ultrasound to look on the inside of the blood vessel, determine what size stents we needed, and we put 3 stents in. I saw him in follow-up a few months later. He'd had a repeat ultrasound. His heart had strengthened to 40%. And when I asked him, I said, can you notice any difference? Like, how are you feeling? He said, I feel like Superman. And it was really rewarding to have, something that we worked for so long on, and something that he thought maybe wasn't fixable, to have such a big turnaround in how he felt.
Okay, so what are some signs and symptoms people shouldn't ignore when it comes to their heart health?
Yeah, I think the biggest thing to pay attention to is a change in your ability to do things. So for activities that used to be pretty easy for you, if you're now finding that you're more limited in them due to shortness of breath or chest pain, more than likely that's your heart's way of giving you a warning sign. It's like, hey, something has changed here. We should be investigating this. So really a change in your functional capacity. Like I said, things that used to be easy, not easy anymore. Seek an opinion from somebody.
So in the patients that you see, how would you say that lifestyle and prevention play a role in the disease that they have?
Sure. So in patients who don't have any heart disease, they've never been diagnosed with anything, we call prevention primary prevention, meaning you don't have anything wrong, let's keep it that way, right? In patients who see me who've already had the diagnosis of coronary artery disease, they've either had a stent placed, they've had a heart attack, they've had bypass surgery, things like that, then we call it secondary prevention. We're trying to prevent or minimize the chances of having a subsequent event. And lifestyle is huge in that. And that, we can put stents in, and stents solve the immediate problem, but the stent can fail just the same way that your arteries can have plaque deposit inside of them, they can deposit inside the stent. So we want to prevent something like that happening. So all the same things that are involved in primary prevention are involved in secondary prevention. Heart healthy diet, physical activity, smoking cessation, blood pressure, diabetes, cholesterol management, things like that. All of those can help minimize the chance of progression of disease, and sometimes even promote regression of disease. So prevention for sure from a lifestyle perspective is always important, no matter if you have the diagnosis or not.
What do you wish that people understood more about the work that you do about interventional cardiology or coronary artery disease, any of those things?
Well, I don't know that this is an answer to that exact question in terms of what wanting people to understand about the job necessarily, but I think when you come to the cath lab for either just pictures or for an intervention, I think what we want people to know is that it's a team effort. That VCU cath lab is an excellent team, from the nurses to the rad techs to the doctors, the fellows, everybody involved, the support staff, and so the credit really goes to the whole team and not just to the physician who gets the credit for it. The other thing that I want people to make sure they know is that we understand that what we do, when we do it, we're taking care of patients at a pretty vulnerable time. And we don't take that lightly. The work that we do is rewarding and we enjoy it very much. But it's also very taxing. It's hard work, it's long hours, things like that. But we're really grateful that we can be there in small or big ways for those patients in those times that can be pretty scary.
Yeah, that's beautiful. I mean, that makes perfect sense. Like you said it's like brushing your teeth, but for the person who is like going in for a procedure, I mean, that's super nerve-wracking.
Yeah.
I don't know anybody who's like excited to do that. So
yeah, we enjoy what we do, but we know that it's not fun.
So after somebody has a procedure with you, do those patients need cardiac rehab?
Yeah, so it depends on what we do. So anybody who has an actual intervention, whether it's structural or coronary, should be in cardiac rehab afterwards. Cardiac rehab is basically a supervised exercise program that's intended to get the patient comfortable with being physically active. So if someone is running marathons before, they're probably not going to necessarily need to do a low-level walking on a treadmill cardiac rehab. But a lot of patients get pretty nervous after they are diagnosed with and treated for a heart problem. And so cardiac rehab is a way to say, look, you're going to be doing some exercise. We're going to be monitoring you completely during that time frame. And it helps build some endurance, but also some confidence that they can then take forward and continue to be active in their life on their own after they complete the program.
And that's something that patients will be able to do at Reynolds Crossing as well, correct?
Yes, we have it at the main campus, we'll have it at Reynolds Crossing, and then there are certainly non-VCU institutions for people who don't live nearby one of ours. So it's not like we're saying you have to keep coming here, but we certainly have the services to offer.
Okay, we're going to do a quick lightning round with Dr. Lawson to round out our conversation. So you mentioned that you played sports growing up. What sports did you play, and what's your favorite sports team?
So I played a lot of sports growing up. The biggest that I was the most involved in was field hockey. But I also swam, I played soccer, I played basketball, I played softball. But field hockey was my big sport. My favorite sports team is UVA, basketball, I guess.
Cool.
I'm a Wahoo for undergrad, so hard to break. Old habits die hard.
Sure. Yeah.
Makes perfect sense. So given that your job is taxing, how do you decompress, like after you work or just in general?
So I run every morning. It helps me stay mentally sound and calm. And it's just a good adrenaline release before I go and have some alone time in the morning, do my run, so that when I'm around people all day, I'm doing stressful, complex things. I already have that sort of mental ease. And then after work, I'm a big reader, so I read a lot of books. Anything, I mean, they can be fiction, nonfiction, whatever, but I do a lot of that.
Okay, what's your favorite book?
Ooh, that's tough.
If you had to pick one to recommend to our viewers and listeners.
I don't know that I have a favorite because there's just so many good ones. But I just recently read The Memory of an Elephant. So elephants are incredible creatures, it turns out, and brilliant. This was about an elephant who was orphaned at a young age and then taken in by rescue and then released back out. And then he finds his way back to where, as he's, approaching older age, it's like his trek across Africa to get back to where the rescuers were so he could basically thank them. It's an incredible book.
So last question, what is a skill that you don't have that you wish you did have? Like something you've never been able to master? Mine, for example, is dancing. Like, I wish I was like a cool TikTok dancer, but I never will be that.
Yeah.
So
I would love to be able to draw, but I do not have any artistic abilities.
I feel like interventional cardiology, you're good with your hands.
I mean, I do draw pictures of heart sometimes to explain what's happening to the patient, but they're definitely not works of art.
Okay, fair enough. Well, thank you so much for spending time with us and explaining what you do, and that was fascinating. So really appreciate you being here. Yeah. And thanks for listening and watching Heart to Heart. We'll see you next time.